red bricks on the screen, healthcare in between. Physics, art, and math got us down this path. Historical tales come alive, where science and stories dive. Blended facts with heart, knowledge from the start. Need bricks, blues we sing, to the future memory. Health and science in the mix, Need bricks got the fix. Complex subjects made clear, every episode with cheer. Ramona leads the way, explaining day by day. In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming. Hey, how are you? This is Ramana, MedBix Webcast. I'm the host of the MedBix Webcast. Let me get rid of this thing and okay. So, welcome to the MedBix Webcast. I'm the Ramana Annamaraju. Our very distinguished guest today. She is the president of a national medical association, the largest African American medical association, physicians. You know, I was a very active member. I'm not a doctor, but I was a member of. I was actively helping and sponsoring a lot of events with Association of Black Cardiologists, National Medical Association. I was involved a little bit, but I have a lot of friends from both organizations, Dr. Williams, Dr. Hargrove, a lot of people, founders, all of them are very well connected with me. And I lived in most of my life in Atlanta, Georgia. I provided diagnostic services to a lot of doctors in south side of Atlanta. So I'm a very connected with the Black community. My ex-wife, she's from the actually South Carolina, small town, Georgetown, So there is absolutely nobody heard probably the town, that she's outside of the town, like my village in India, small place. So I am really passionate about this. American healthcare system is a paradox. We spend more money, healthcare access and quality going down. What is equity is not even equity is the biggest problem now. Then on the top of it, we have an AI bias that's coming up from Silicon Valley, where I'm from. So we need to address a lot of problems. So I have a Dr. Yolanda Lawson. She's a she's the immediate past president of the National Medical Association. I met her actually. Then I attended a few conferences of NMA. So I really wonderful time, so I learned a lot. I met a very distinguished people from there. Because I'm living in Atlanta is a very epicenter of Black culture. I know my office was next to the Martin Luther King's birthplace on Auburn Street. So I'm very connected with Atlanta and the community itself. So I'm always fighting for the equity. It is a very easy to provide. Equity is not that difficult. It's not even expensive. I don't know why we make it so complicated. We will ask this one. We ask these questions. Dr. Yolanda Lawson, she's an OB-GYN from a doctor from Dallas, Texas. You cannot get anything hotter than that. Let me introduce. Welcome to the MedBix Webcast, Dr. Lawson.
Good
Tell
evening.
me a little bit about your background. I met you, but just give us a rundown of little bit about your background.
Certainly. As you stated, I am an OB-GYN. I'm based out of Dallas, Texas. I actually grew up in Arkansas and I attended the University of Arkansas for Medical Sciences for medical school. And I've been in practice a little over 20 years here in Dallas. Texas, and I just again am the immediate past president of the National Medical Association. And during my tenure, I had three pillars that were of extreme importance to me. The first was the Black women's health agenda. And within that, really my focus was around cardiovascular disease in Black women. We understand those disparities, HIV disparities in Black women, and of course, the maternal mortality and reproductive health care issues. Secondly, I focused on digital health equity. So as and hopefully we'll explore that a little bit tonight, thinking about the technology and innovation that's being provided in healthcare now, and but will it really close the equity gap? And just I want to ensure that communities of color and the underserved are not left out of the conversations. And then lastly, the physician workforce. It was extremely important to me. There are a lot of pressures on physicians this day. We know we continue to hear about shortages, but I'm equally concerned about preservation of the existing physician workforce.
You know, before I go into serious mode, I wanted to ask you. I saw something on YouTube. You said that you're after 10th grade, after the physics class, you move you move to medicine. You're talking with a physicist now. I'm going to ask you a lot of physics questions. Just kidding. But
Yeah, let's not discuss physics. That was 10th grade.
yeah, that's very interesting. Now it's ironic you're talking with a physicist now. Um, so you know that as you say that this is what is the NMA's mission? He eloquently said that all the four agendas he had: equity, and then women's health, and the cardiovascular health, and the maternal mortality. All those are important. Let us talk about different topic a little bit about clinical research. You know, one of the things is that the active participation of the, let us talk with the pay, you know, the phase one, phase two, phase three, right? Phase one is basically a small number of group with the with the dosage and the amount of the dosage. The second one is efficacy. Phase two, phase three is a large group that you do with large group. So in this phase, why it is always there is a, everybody knows, a lot of people in the healthcare industry know about Tuskegee experiment. So a lot of black community is very skeptical about these clinical trials. But you know that is a, tell us a little bit of background about that and why we need the diverse. You know, I interviewed, actually I want to mention to you this one. I interviewed a doctor from Stanford. She's the Sophia Yan, Dr. Wobi. She does birth control pills and all those things. Pandya Health, the CEO. She was telling me most of the medications they got it. She's the Asian woman. She was telling me that most of the medications don't work for the black community or other races. You know, because there are most of them are they geared towards the white woman and those kind of. I was surprised. You know, we as a man, I didn't know much. I didn't pay attention to it. Now I have a daughter that I got to worry about. So let me ask you a question. Why do we need the now that is a leeway to the why we need a diverse participant in the clinical trials. Tell us a little bit about the clinical trials aspect of it.
Absolutely. So you mentioned the Tuskegee study. And so historically, you're correct. Historically, Black people have been reluctant due to mistrust of the system, right? That was government. And that's not the only example we could discuss tonight. We could think about cancer treatments and how Black persons were experimented on with cancer drugs, right? So we have those historical instance that occurred. But I think in modern times, in modern day, one thing I'm highly concerned is while we know those are historical perspectives and historical truths that occurred, I also am highly concerned if Black people, minorities, even Hispanics, right, are offered clinical trial acceptance and enrollment. So that's a high level concern. So when you think about there's a piece of the mistrust But that's also this piece that are we equally offered, right? Enrollment into clinical trials. When you look at clinical trials at present, if we look at 2020 data, about 75% of trial participants are white people. Yet, around 40% of this country, right, is represented by minority populations. Even in one of the things that I commonly talk about also are the disparity between women. Women, of course, are not equally represented in these trials. And so you're correct in that when we think about disease states, we think about drug efficacy, of course, there is concern that things may not work, treatments may not work in us as well. You could take the instance even of women. Sometimes the side effects that women may experience may be different. And a lot of that just wasn't studied, right? Because if there's not representation in the trial concordant with the population, it makes it challenging. Not only does it make it challenging for the patient, it also makes it challenging for us as clinicians to have confidence in the therapies and the treatments and the drugs we're recommending if they'll work on our target populations.
Absolutely. So, you mentioned the cardiovascular problems. Some of the beta blockers, for example, ACE inhibitors, did not work with a lot of colored, people outside of the white color. Non-white say did not work very well effective. That's a proven fact, in fact.
It
So,
is a
so
proven fact,
yeah.
yes.
So like, for example, anticoagulant drugs didn't work with a lot of these things. So so these are the things that why we need to do that you made a case for why we need to recruit black patients as a important participant in the clinical trials. They are an important component of the any clinical trial should be, right?
Absolutely.
So
It's
let me ask you on the other way around. Just not a black patient to know you're the NMA past NMA immediate past NMA president you are, but without the doctors, black doctors, that the cultural competency, understanding the culture, connecting with the cultural things, it's much more makes sense. So to recruit more black physicians to be part of the clinical investigators. Tell us a little bit about that if you don't mind.
Absolutely. I can give you a personal story. This was approximately 2015, and I really wanted to be a researcher. I wanted to um, I wanted to enhance my career, right? And so the new fibroid drugs were coming out. Here I am, a Black female OB-GYN in the South. I have the perfect patient population. I pursued it, and I had site visits. I thought, oh, this is great. I'll be able to actually study this and enroll and ensure and do my part, right, to ensure representation in the studies. And I was not selected. My site was not selected, and I was told because I did not have a full time right research nurse. And so I shared this story with my mentor, and he was very upset and angry. And he said, that's the problem. They should have helped you, right? Get the wrapped those services and helped you get the things that you need, because I certainly have the proper patient profile. So fast forward, I'm the current and principal investigator for a study now, because I really kind of gave up. It was very difficult for me as a Black doctor to obtain um, to
Any
get a research
clinical,
study. It was very
yeah,
difficult. And so
yeah.
fast forward a few years ago, there was a study. And so I'm the principal investigator of a study now. It's called the Ebony Study. They're only recruiting Black, cis, and
Oh, really?
transgender women. And this is around HIV prevention, the injectable drugs. But the reason this is important, because this company, obviously, we know that, again, HIV is another therapeutic area whereby women are understudied. And of course, when you look at the disparities of the epidemic in this country, I don't have to tell you, but we know who's affected, the Black and brown people, and certainly Blacks. When you look at 1 and 2 men who have sex with men or have a lifetime risk, right, of
Yes.
contracting HIV. So it's very important that we're represented in these trials and studies. And so I'm really happy to say I'm a principal investigator for that trial now. But again, that was a specific strategic and intentional, right, action by that company to recruit, right, Black investigators to reflect what the epidemic is in this country. Because, I think that I had one of my colleagues ask me, was I having difficulty recruiting for this study? And absolutely not. And I think it's because of that level of trust exists, right? And so we know that these disparities exist in this country. I could go on and on with you tonight talking about whether it's disparities with cancer for Black people, lung cancer, leading cause of death for Black men. Black men are twice as likely to die from prostate cancer. We could talk about cardiovascular disease. I don't have to talk to you about maternal mortality. All of these disparities exist. And I think this is one of the most important things we can do. Thinking about representation and diversity within trials to eliminate the healthcare disparities that exist in this country.
So you're a recipient of a Johnson and Johnson fellowship, NFC something. Can you tell us a little bit about that? You said that you wrote a very nice piece about that. You mentioned about it in the on the
Let
article.
me offer you clarity. So Johnson and Johnson highlighted the fact that so National Medical Fellowships is an entity that actually provides scholarships to disadvantaged medical students.
Okay.
I was a recipient of one of those scholarships as a student. Fast forward, they offered a diversity in clinical trials training. They were training physicians of color to become principal investigators. So they had a structured investigator training. And actually, I was one of the matriculants, and Johnson highlighted that fact.
Okay. Very good. So let us talk about that a little bit. What are the things now you talked about? This is very important to recruit the physicians, Black physicians in the clinical research program. What are the things that Let us talk about solutions a little bit. If a good company has a good intentions, wants to do that, sometimes they may not know even. So what are the things you need? As you said that you needed a nurse at the time, full time. So what are the things you usually need to not only computer information, a lot of computer technology you need a lot of assistance. So tell us a little bit, what are the requirements you need as a physician point of view, from a physician point of view?
So I want to back up because you said something they may not know, but I would beg to differ. We know that the FDA has placed an emphasis on equity in clinical trials. We also know that the NIH has placed an emphasis.
Yes.
So it's recognized. I think we all know that there is underrepresentation,
Yes.
right, of minority populations in these trials. So I don't think that it escapes them, but I do think that many companies in the industry as a whole has not been willing, right? I understand this balance. They want to go to the larger academic centers. They feel that they know that those people have the structures and will deliver for them. And so I what I've been told, that there is reluctance, right, to engage sometimes minority populations that may not be tried and true. But I do think what NMF did and others are doing, investing into developing, right, researchers and
Mm.
investigators of color is a worthwhile effort. If
Absolutely.
if you continue to say you want to solve the problem, we continue to hear that. We continue to hear advancing equity. And so I get concerned because I just don't want that to be a trendy phrase or word. I want individuals and entities to stand behind that, right? I think, again, we recognize the issue.
Oh
What
yeah.
do you have to have in place? I think that it depends, right? You talked about phase one, phase two, phase three. The study I'm engaged in now is an implementation phase. So I think there are multiple areas and how you engage, where you want to engage. I think there are, for many of our young early careerists, I find that there are several opportunities for them, right, for early career trial enhancement and courses that they can take. I'm a mid-careerist and I did it, right? I put myself in a position to learn more, being very intentional about what I wanted to do with my career. So I would beg to differ with you that they don't know. I think it's known. I just think that people have to be very intentional
Yes.
how they are going to go about solving this problem.
Yeah, actually, let me correct that my statement. If they have a good intentions, what they want to do, what they need to do, that is a second part of the question. If they have a good
Secondary.
intention, yeah, that is no question about that. This is the American healthcare system. I wanted to ask you. Not only you're saying something different now. Is you have a discrimination towards independent doctors versus academic institutions. They need to have. Why don't they help the independent doctors, particularly people like you, who are practicing in real communities, right? The academic institutions are in big cities, big places, but rural areas. If I go to Baxley, Georgia, or Vidalia, Georgia, you don't have the academic institution there. So you need an independent. They are the one in the communities. Why don't they select those people? Why don't they help them to be investigators in their trials? That is an important aspect of recruiting and getting a diverse patient population, right?
I agree with you. I think that there is beginning to be a bit more trend around community based participatory research. I hope that that trend continues. I think it is important. We continue to hear the difficulties these companies state they have reaching, they call hard to reach populations. So I do believe that community based participatory research is important. I do believe that them looking at unique and innovative ways to get those populations to have a diverse pool, right, in their clinical trials is important. And that may mean that they may not have to go directly and only to these larger academic centers. But the big piece to this, even if you do go to an academic center and they promise you, right, that they can deliver a diverse set of enrollees, right, in these clinical trials, what I have not seen is that they hold them to task,
Hmm.
right? And
Interesting.
they continue. That is my issue. I'm not saying it's wrong. They have that right. And so whether you're independent or some of these community-based organizations, whether are smaller or larger independent practice, whatever that is, I want there to be more strategy and intentionality about enrolling diverse populations in clinical trials.
Absolutely. You gave a very good rundown on the clinical trial side of it for the minority provider population, participation. That is where all the pharmaceutical companies, not only the problem now, the medical devices, for example. Let us talk about the medical devices. Pulse oximetry is one of the things they found out that the device itself, as these oxygen saturation levels are showing a different ones. During COVID, I don't know how many people died because of the bad readings. That is. Tell us a little bit of this medical testing. The device also, they need to select a lot of black physicians at a better sites. Would you agree with that? Of course.
Oh,
What do you think?
absolutely. Whether
Yeah.
it's beta sites or again, whether you're talking about drugs, whether you're talking about medical devices, right? Especially something that is an assessment or a diagnostic tool, such as the pulse oximeter. Again, it wasn't recognized until throughout the pandemic that was recognized that the pulse oximeter did not provide accurate readings for African Americans due to our darker skin. Thus, you had African Americans who received less oxygen and didn't necessarily receive the care that they should have received. And you're absolutely right, either suffered morbidity or died. And so again, this is root cause of exactly what we've spent our time talking about tonight, is ensuring diversity, right, within these studies, whether it's a diagnostic tool such as the pulse oximeter or it is a drug. It's the same root cause issue of not ensuring there's enough diverse populations to ensure concordance and consistency, right, with results and accuracy across the different racial groups.
Dr. Lawson, I am from a small village in India, where I grew up in a very small, rural, poverty stricken village. It is the OB-GYN is basically the maternal care is almost non existent. And I know one woman, a few blocks from me, died right in front of us because of ectopic pregnancy. So, as advanced as this country is now, I am hearing the rates of the maternity mortality rate is United States is lagging behind almost all industrial nations. Tell us what is going on. You're OB-GYN doctor. You're on the front lines of this one. What is going on in the maternal mortality? Where is the problem exactly in this area?
Right. So you're absolutely correct. Out of the high income developed nations, the US lags behind and has some of the highest rates of maternal mortality. And then also, but I really like to ensure that everyone understands that's all women in the US, right? So
Yes.
all women in the US fare worse than women in other developed countries. And then when you look at the disparities in the US for Black women, there's so all women, and then US Black
Mhm.
women fare even worse and actually poorly when it comes to their maternal health. There are many sources of these inequities, right? So I don't always say it's just one thing, right? We know that healthcare access is important, and but it's also quality access. So I often like to make sure we're using the correct adjectives, right? So even when you look at women who are accessing lower quality facilities, lower quality care, their mortality and morbidity is higher. And of course, Black women, Black and Brown women typically access lower care facilities. Also, the insurance rate, right? And so when you look at 40% of births in this country are insured by Medicaid, about 51% are insured by commercial insurance, right? But insurance. So many women go into pregnancy uninsured. So many women would get out of pregnancy uninsured. So it's been a triumph that many states, I think we're down to maybe 6 that haven't expanded the postpartum extension to 12 months. That's important. I can tell you for years, women had the coverage for 6 weeks after birth. We were cramming in all the health care we could within a 6-month period. But you and I both know that won't meet everyone's needs, right? When you have hypertension and these ongoing needs for yourself. And so we have many issues going on in this country, addressing the social determinants of health, right? How do we get healthcare access to more people? You now have maternal healthcare deserts, you have high rates of preterm birth. We also, Black women, Black babies are twice as likely to die. We now have these mental health issues. And so when you look at the two of the leading causes, they are cardiovascular and then the mental health and substance use piece. So we have tremendous work to do in this country. But while I say we have tremendous work, we also have tremendous opportunity.
Oh, yeah, absolutely. So, I used to provide ultrasounds, radiology side of it in the rural Georgia. And then, some of the women, including white and black, all of the women in rural areas, they didn't even know until seventh month they have twins. That is a staggering for me that, coming from India, I thought they all have this one here. I was surprised at how behind this situation is. That was a wake up call to the, this is inequities of healthcare is unbelievable. That is we have to address that. That is the Martin Luther King says injustice of all, inequity of healthcare is the worst injustice, right? That's what he said.
That is correct. Yes.
So let me. So the now let us go to the. You asked about the mental health. Let us talk about mental health a little bit. I am a member of AREACH, an organization in Atlanta, Georgia, is providing a black youth the mental health support. We introduced a technology like a VR, virtual reality, and neurofeedback systems that I introduced it through an organization called AREACH, and I provided technology assistance for them in that area. It was a widely successful. Actually, everybody loved it. She's growing. The woman that I work with, Cathedra Phillips, and she's doing that. She's growing, and then she really, I'm a board member there. But it is really, it is mental health is one of the ignored ones in the. My son is a neuroscientist actually from Vanderbilt. He was actively involved with that organization, in fact. So tell us a little bit about mental health problems. That is one thing people don't talk. It is a myth that black people don't have mental health problems. This is kind of a thing. To tell us a little bit about that, what is going on with the mental health situation among the black communities.
That's black people don't have mental health problems. Black people don't like to necessarily
It is
necessarily
a myth, right?
accept,
Yeah,
right?
yeah,
Necessarily accept. Oftentimes we are actually underdiagnosed,
yes,
right? So that is a real thing that many times we are often undiagnosed. It may be, again, if you do not have a physician or a healthcare provider who may be culturally competent, who understands culturally, right, your natural behavior. Sometimes it could be related to stoicism a little bit. And so that is a common thing. And so that's why that cultural concordance is so important, of having enough doctors of color to take care of all the various racial ethnicities in this country. That's why that's important. Because the other thing, so you have underdiagnosis, you have undertreatment. Oftentimes, and studies have shown, I'll give you an example for Black women, for instance. Even if they are prescribed an antidepressant, they're generally prescribed a shorter course,
yeah.
right? And so Black women tend to also rely on spirituality. And so it is always effective for me to offer, other than just medicine, right? Therapy, counseling, these other wraparounds to help one with mental health. But it's quite challenging. You also look at Black men. We're seeing the rates for Black children, right? Suicide rates are going up. And so we've got to, for me, it's a public health crisis. We've got to continue to talk about it more. We've got to continue to remove stigma. In my opinion, stigma is one of the biggest barriers, right, for our Black communities and our minority communities when it comes to our mental health.
From coming from other countries, I can tell you, in the United States, mental health is equally distributed, equally
Right.
messed up everywhere. you
It's
know,
everywhere.
everywhere. The stresses of the system. It is we have. I came from a village in India, and then I married a woman from a small, you know, Georgetown, South Carolina. There's not much pressures now. With all the pressures coming up, and enormous pressures are added to the everybody, and it is becoming a big problem in the mental health issues. That's one thing we need to. That's a bigger than economic crisis, in my view. Mental health crisis is going to be humongous crisis if you don't address it now. It is slowly spreading across the world, not just the United States. It is becoming a epidemic in the world itself. Maybe because of the processed food, we don't know, whatever the reasons are, that we don't even know the exact reasons are, that we are having a lot of one of them could be technology pressures. Let us talk about the technology a little bit.
Yeah, life is a lot more complicated for us, and for me, I can say, than for my mother and my parents.
Yeah,
Life is much more complicated. There are many
yes.
more demands. Yes.
There are benefits, but see that you and me are talking together, but same time there's a lot of pressure is added to the system, and then there is no coping mechanisms are not in place. So that is a bigger challenge. Let us talk about, I this is a one. I'm from Silicon Valley, and I lived in Atlanta, and I lived in South a long time, 30 years. I lived in Silicon Valley, in Atlanta. I know the problems in the South. I placed doctors in Alabama, Georgia, South Carolina. So I know the problems there in existence. Then I came to Silicon Valley. It's a bubble. Silicon Valley is a bubble. They don't even know these are, besides the color itself, you don't see hardly any black people here. Besides the color, all of them are, if you are 30-year-old, they think you're retired. You're old, too old for them. So they have no health problems. They don't understand health problems at all, these kids. So they're trying to solve health problems, and they want to write this is a AI bias. That's where they're coming up. Even they are good intentions, they may not even know what exists in the AI. One of them is we is a documented evidence, right? A kidney functions, and then the sepsis detection, and all these things are not well done with the minority population. It's a very AI algorithms itself is biased towards the detect these things. Tell us a little bit about AI, if you know anything about digital health and AI bias. How did they, how we can solve this problem, and tell us the what do you think of it?
So, how do we solve the problem of bias in AI? That's a loaded
A
question.
lot of question,
I
yeah.
don't know that anyone has that answer, but I do know that I will share with you, of course, it is a high level concern. I can say that the National Medical Association, I believe the American Medical Association, I mean, many of us are all aligned, right, of the concern on the bias being built into the tools, right? We know that there's, again, historical references where this has happened before, but this is happening so fast. The innovation and the technology and the tools and where they're being utilized, I would offer to you that many clinicians probably don't even recognize all the aspects of how we're using and how AI is being deployed in our day-to-day work, whether in our clinics, in our hospital, and in all of our settings. So as far as, is there a solution against this? I think that you're right. I know who the data scientists and I know the technology guys, and they're young. Hopefully, we can only continue to put advocacy pressures there where they ensure that they are being informed, and informed by doctors is important, and informed by a diverse group of sets of doctors and scientists and others. I think
And
it needs to be a collaborative effort to do that, because it is strikingly fast how these tools are being used in so many deployments in our electronic health records, the prompts, all of the things. And so it's quite concerning, the impact and the implications this is going to have on healthcare. But also, again, as I challenged and discussed with you earlier, the challenge is, will it really close the disparity gaps that we have in this country? Will it really do the things that we have been promised that it's supposed to do for us? Right? That is my concern.
One of the thing is that I strongly feel that is from my point of view, from the Silicon Valley point of view, they need to recruit more black community engineers. We need a lot more engineers, electrical, in the computer side, in the coding side. I have a Kimberly Brandt. She's a very active member here. She does the Black Girls Code, the program she runs it. She's a good friend of mine. So we need more people like that, more active members there, and recruiting more people there. Then the people get aware of what they can give input in that direction. Even though these young kids may not know all the bias and all those things, they grew up in bias, but they may not have an intentional bias, but they grew up in that bias. That's a big problem. So we need to solve that by recruiting more black engineers, black computer programmers. I think that's a very valuable asset. Not just not only Indian. As an Indian, I'm talking about not just Indians and Chinese. We need to have a lot more diverse group of people in the technology side. That would be us, that would solve the problems a little bit.
I get concerned even on that. The data, the scientists, the engineers are doing one part. They're trying to make something work. I'm probably most concerned from a clinical application
Yeah.
when it's going to be used in healthcare. You really do need to be informed by clinicians. It is very, their work is completely different. Their focus as an engineer is on building that tool, right? And so sometimes when you're asking these tools to ask questions and things, you have to be very careful. And I commonly encounter this. And I do this work. I work with data scientists. I love innovation. I go to hackathons. I'm engaged in that space, but that it needs to be clinically informed, where it is again a holistic approach.
Oh, absolutely. With I am just in every level there need to be participation. If it is
Yes.
not there, it is not just a with just the programmers only can. So they just can code it, but they need a perspective of the clinicians, a very
Yes.
important aspect of the clinical research and everything in that programming, particularly in that area. These technology companies need to have a consultants. They need to allocate funding for the minorities and see this. That's where the funding. Let us talk about the funding part. I think that's one of the advocacies missing here is the Silicon Valley companies asking for advocacy groups asking for funding. You need to allocate when you write any healthcare related program or any program you write. We want to allocate some money for the equity funding that makes sure that is comply with the equities and then is fair to everybody. That is one thing is missing. In fact, at the seeking for funding and active advocacy in that area. I think people like you can do that probably in the future. That's where it makes a huge difference. Let us talk about a little bit about music. My son is a neuroscientist. He is a he says that music is he's a rapper and he's a master's in neuroscience from Vanderbilt, and he wrote a lot of music and everything. He says that music has a power to heal a lot of mental health issues. So the sound as a therapy, actually the NIH started a sound therapy. Do you have some idea about this music as how do you, em- employ this music area for your moms and children and to soothing them out, the worries? What do you think of the music as a part of the disease protocol?
I'm so shocked that you asked me that question. So I actually am working on a musical therapy project now. I definitely believe in music therapy. You're right. Dr. Francis Collins, NIH, right? A focus there. Many of the hospitals, my own hospital here, we have musicians. There's a musical therapy program at my hospital. Musicians play. We have harpists, pianists, and others who play in the hallways, many of our medical surgical floors. I'm actually working on a musical therapy project now. It's called Classical Therapy, looking at the impact of classical therapy on pregnant women. We know that it can reduce anxiety. We know that it is good for the neurocognitive aspects development for babies. So that's actually a personal passion of mine. So I didn't know you'd ask me that question, but yes, I definitely endorse it. And I would love to have a conversation with your son.
Yeah, absolutely. My son is very actively does that, and he was a binaural beats he is talking about. I didn't even know they exist something like that. So he was talking about there's a lot of mental health issues. One of the areas he's employing is a music as a therapy. It's a very effective way to reach even the communities and then much more. So that is a very tool. That's where um, not only that all of them together is that we are all with the music can bring all of them together, all the races. So give us a final thought about yours. Tell us a little bit about what is our next steps are and what is planning to do next steps.
So currently, I'm in a role and I'm focused on maternal and infant health and rolling out initiatives. One important aspect for me in all of the work that I do is that there is a community impact. That is highly important to me. So I think we can all work in our ivory towers, right? I think
Mhm.
it's very important that we are all in community informed when
Yeah.
we are deploying. We talked about drugs, we talked about devices, we talked about technology innovation tonight. I think it is so important to be community informed when you're working on things that are you expect the community to adopt and digest. So that is my role now. I am quite active and participating in community impact projects. And so, but thank you. I'm really honored that you would reach out and want to have a discussion with me and have this conversation. I really enjoyed it.
It is truly an honor to have you, Dr. Yolanda Lawson. It's truly an honor and privilege. You are so informative, and you're one of the leading figures in the Black community, in the Black community, physician community. Thank you for joining with us. It's an absolute honor.
Absolutely. Thank you.
Good night, all of you guys. Good night.
Telling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it